This is part 3 of lecture 10 on cardiovascular physiology. This information can be found in chapter 18 of your textbook on pages 671 to 702. Cardiac output. In this diagram, we see a lot of information represented. At the bottom, we can see an animation of blood flow from the atria to the ventricles and from the ventricles to the pulmonary artery and the aorta of the heart. The black line represents ventricular volume in milliliters, all the way from 50 to 120 milliliters as it rises and decreases with filling and emptying of the ventricles. This section represents pressure in various chambers of the heart, with the violet representing pressure in the left atrium, the blue representing pressure in the left ventricle, and the green representing pressure in the aorta. And at the top, we see a representation of the stereotypical electrocardiogram, or ECG pattern of the heart. The volume of blood pumped from each ventricle in 1 minute is cardiac output. This is a term you need to know and understand, and you will need to know in the subsequent course, exercise physiology. Cardiac output is made up of the number of times a heart contracts per minute, or heart rate, and how much blood is ejected from the ventricle with every contraction, or stroke volume. Normal resting cardiac output is approximately 5 to 5.25 liters per minute. If you want an idea of how much blood this would be, go to a standard kitchen or bathroom faucet and turn it on all the way. That is roughly 5 liters of water in 1 minute. Stroke volume is a volume of blood pumped out by each ventricle with each contraction, and it correlates with the force of contraction. That is, the stronger the contraction, the higher the stroke volume. At rest, cardiac output is equal to heart rate multiplied by stroke volume. Maximal cardiac output in non-athletes may be 4 to 5 times resting cardiac output, or 20 to 25 liters per minute. In elite trained athletes, cardiac output at max can be up to 35 or 40 liters per minute. Cardiac reserve is the difference between resting and maximal cardiac output, and cardiac output is always affected by stroke volume, or heart rate, or both. In terms of the regulation of stroke volume, mathematically, stroke volume is equal to N diastolic volume minus N systolic volume. N diastolic volume is the amount of blood in the ventricle at the end of filling, and systolic volume is the amount of blood in the ventricle at the end of contraction. N diastolic volume is affected by the length of the ventricular diastole and venous pressure, and is approximately 120 milliliters per beat. N systolic volume is affected by arterial blood pressure. That is, the higher the arterial blood pressure, the more difficult it is for the blood to exit the heart, as well as the force of ventricular contraction, and is approximately 50 milliliters per beat. Therefore, the normal stroke volume would be N diastolic volume minus N systolic volume, or 120 milliliters minus 50 milliliters would equal 70 milliliters per beat. The 3 main factors that affect stroke volume are 1. Preload, 2. Contractility, and 3. Afterload. In terms of regulation of stroke volume, preload is the degree of stretch of a heart muscle, and is really the degree of which cardiac muscle cells are stretched just before they contract. Changes in preload will affect changes in stroke volume, and affects end diastolic volume. The relationship between preload and stroke volume is called the Frank-Starling law of the heart. Cardiac muscle exhibits a length-tension relationship. At rest, cardiac muscle cells are shorter than optimal length, which leads to a dramatic increase in contractile force. The most important factor in preload stretching of the cardiac muscle is venous return. The amount of blood returning to the heart. A slow heart rate and exercise increase venous return. An increased venous return distends or stretches the ventricles and increases contraction force. Contractility is a contractile strength at a given muscle length and is independent of muscle stretch and end diastolic volume. Increased contractility lowers end systolic volume, and this is caused by sympathetic epinephrine release that stimulates an increased influx of calcium, leading to more cross-bridge formations. There's positive inotropic agents which increase contractility, such as thyroxine, glucagon, epinephrine, talus, and high extracellular calcium. It is also decreased by negative inotropic agents, such as acidosis or excess hydrogen ions, increased extracellular potassium, and calcium channel blockers. Afterload is a back pressure exerted by arterial blood. Afterload is pressure that the ventricles must overcome to eject the blood from the chambers. Back pressure from arterial blood pushing on the semilunar valves is a major pressure. Aortic pressure is around 80 millimeters of mercury, and pulmonary trunk pressure is around 10 millimeters of mercury. Millimeters of mercury being the standard measure of blood pressure. Hypertension, or high blood pressure, increases afterload, resulting in increased end systolic volume and reduced stroke volume. If stroke volume decreases as a result of decreased blood volume or weakened heart, cardiac output can be maintained by increasing heart rate and contractility. There are positive chronotropic factors that increase heart rate and negative chronotropic factors which decrease heart rate. Heart rate can be regulated by the autonomic nervous system, chemicals, or other factors. In terms of autonomic nervous system regulation of the heart rate, sympathetic nervous system can be activated by emotional or physical stressors. Norepinephrine is released and binds to beta-1 adrenergic receptors on the heart, which causes a pacemaker to fire more rapidly, increasing heart rate. End diastolic volume is decreased because of decreased fill time. Increased contractility is when end systolic volume is decreased because of increased volume of ejected blood. Because both end diastolic volume and end systolic volume decrease, stroke volume can remain unchanged. Parasympathetic nervous systems oppose sympathetic factors. Acetylcholine hyperpolarizes the pacemaker cells by opening potassium channels, which slows heart rate and has little to no effect on contractility. Heart at rest exhibits a vagal tone. The parasympathetic nervous system is dominant and influences the heart rate. It decreases the rate by about 25 beats per minute. Cutting of the vagal nerve will lead to a heart rate of approximately 100 beats per minute. When the sympathetic nervous system is activated, the parasympathetic nervous system is inhibited, and vice versa. In terms of the atrial reflex, this is a sympathetic reflex initiated by increased venous return, hence increased atrial filling. The atrial walls are stretched with increased volume, stimulates the SA node, which increases heart rate. It also stimulates atrial stretch receptors that activate sympathetic reflexes. In terms of chemical regulation of heart rate, hormones, such as epinephrine from the adrenal medulla, will increase heart rate and contractility. Thyroxine will also increase heart rate and enhances the effects of norepinephrine and epinephrine. Intra- and extracellular ion concentrations, such as calcium and potassium, must be maintained for normal heart function, and imbalances are very dangerous to the heart. In terms of other factors that influence heart rate, the first being age. A fetus will have the fastest heart rate, and heart rate will decline with age. Gender also can affect heart rate, with biological females having a faster heart rate than males. Exercise will, in the short term, increase heart rate, but trained athletes can have a slower or lower resting heart rate or heart rate at a given exercise intensity. And an increase in body temperature will increase heart rate. This is the end of this section on cardiovascular physiology.